Remsco, jeepers. I'm skipping ahead. I want to go home already. REMAC meeting to order. We do have a quorum of docs, and Amanda has taken roll on paper as people have entered. Can you pull up the flag? And screen share. And we'll do the pledge. As I knock over the heater and light the place on fire.
Oh, good.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you. The October 16th meeting minutes were sent out to everyone. Does anybody have any changes or recommendations for them? If there are none, then we'd entertain a motion to accept as written. Dr. Coates makes the motion. Do we have a second? Dr. Howland, all in favor by a show of hands. Carries. Correspondence, can we pull up the DOH correspondence, please? Or DOH enforcement list, and Debbie will go over this.
Can you zoom out? Yeah. Okay, so these are the ones since our last meeting. So the first one is a person from Albany, 800.1685, convicted of one or more criminal offenses. His certification was revoked on 10/16. The next one is Seapole from Yorktown Heights. A bunch of them. Incompetence, negligence, required training curricula, failure to comply with requirements, negligent, incompetent. Suspended for 3 years, civil penalty of $1,000. The next one is Rivera from Carmel. Negligence and fraud or deceit with regards to certification. Whoops, no, sorry, that's the next one. Negligence. 3-year suspension, civil penalty of $1,000. The next one is George from Somerton, South Carolina. Fraud or deceit with regards to certification or recertification. Certification revoked at 10/20/23 plus a civil penalty of $500. The next one is Langevin from New Milford, Connecticut. Incompetence, negligence, state-approved curricula, protocols, negligent, incompetent, 3-year suspension, civil penalty of $1,000. Cusino from Staten Island, confidentiality, suspension of 3 years, civil penalty of $1,000. Lugo from the Bronx, certification revoked, and that's all it said on there. It didn't say why. And it was revoked effective 8/17/22, but it just came through with, I don't know if it should have said 23, but in the letter it said 22. And the last one, and this is one that at Rumsco we're going to talk about, Stanford Fire Company, discontinued operation for a period in excess of 1 month, and they surrendered their ambulance CON on 1/9/24. But we have some ambulances in our 3-county region that kind of fall under this. So we're going to talk about that a little bit more at the Rumsco regards to that. Any questions on the enforcement list?
So we do have one correspondence, but it's covered under protocols, and it's a Fort Drum ambulance request for ketamine to be a standing order. We can handle that now, or we can wait till we get down farther. It's really up to you. Okay. All right, so a little bit. So Lindsay Baldwin from FDR HBO is here. She's going to discuss the Matters program and initiative that we are going to be starting from the program agency. She's at the side, so she can screen share.
Thanks, Jonathan. I can share the slides, and then I can also give them to Jonathan if anyone wants to go through in more detail. It's going to just be a really high-level overview today and focus on the EMS piece and where that comes in. So I'm going to take control. Jonathan, can you see the screen? Yes, okay. Jonathan, was that a yes? Okay. So Matters, it's what it says, it's medication for addiction treatment and electronic referrals. This was a platform that came out of an emergency room in Buffalo. And it has since gotten New York State buy-in and backing, and this is hosted within the health commerce system. So the goal is to connect patients with opioid use disorder to treatment and rapidly. So where originally it did connect individuals at the emergency room, it quickly was determined that it's not just emergency rooms, it's law enforcement, it's EMS agencies, it's community organizations. Who are these community members presenting at, and who can connect them to treatment as quickly as possible? So this is where the EMS agencies come in, and because a lot of the times that these patients might not even make it to the emergency room. So there's a couple different avenues that we can take a look at. So they do have a leave behind program if that person is not ready to say, yep, refer me to treatment. That's where this telemedicine bubble comes in. There is, for New York State, a telemedicine provider that's available from 11 a.m. to, I'm not sure if it's the full 12 hours, but it could be 11 a.m. to 11 p.m. Say, and they will prescribe buprenorphine for these individuals until they can get to an outpatient treatment facility. And we have partnered with a few Jefferson County treatment organizations who will accept these patients and get them in within that 72 hours, which is recommended. So we've partnered, as I said, in Jefferson. We'd like to expand this also to St. Lawrence County. So we're starting with treatment providers, and then pretty much at the same time are also looking at community organizations, at EMS agencies. And we have peers, so we have Anchor, we have NERCL, because at the same time, when you refer to a treatment organization, these patients are asked if they would like a peer to support them through this process. This platform also connects them to transportation. So this one is not working this moment, but VTC has signed up and we're in the contract phase for getting them to accept these patients to get them to their first appointment. And then there's also medication vouchers. Bolton's already is signed on for this. Kinney's is shortly following. They've got the verbal yes. But they will provide medication vouchers if a person is uninsured or has medicated or is underinsured, if there's a copay, for example, that they will provide the first 14-day script for these people. So I will, as I said, kind of skip through. You'll see this is where the organizations are now, the partners. There's a very big gap in this North Country area. Our goal right now is to fill that gap. And we are, as I mentioned, kind of our partner's name, working aggressively toward that. The referral platform is available as an app. It's available as a website. So if an EMS agency does want to take the time to be onboarded, to be a referring partner, they absolutely can. There's just some training that they have to do. But it might be handing over an iPad if the agency has an iPad, or facilitating with that patient to get on their phone and to do that referral kind of face-to-face when they're there with that patient. They try to keep it as a pretty simple process to sign up for this referral. And then at the end of it, you'll see that this is kind of what comes out of it. You've got the info to the referring site goes back to you. So that would be the EMS program agency. They would get that to then facilitate with the individual EMS agencies. The information would go to that treatment organization for them to follow up within 24 hours to schedule that patient with an appointment within 72 hours. Then if that person selected, they need a medication voucher that automatically gets sent at the end of this process. If they want a peer, again, that gets sent right to the peer agency, and then email back to the patient or a text to confirm all of these things. So that's the process. And as I mentioned, there's another strategy of the Leave Behind program. So right now, Matters does offer these 3 things. You'll see the naloxone, the fentanyl test strips, and the excuse my pronunciation of the might not even try the other test strips. So that is available to any partner who signs up. They are an agency that does this on behalf of New York State. That's where they're getting their supply from. They would do the naloxone only with the intention of that agency taking over because they are an OOPP. So is the program agency, but that would have to kind of transfer to be the responsibility of that group to eventually provide the Narcan or the naloxone, I'm sorry, for the Leave Behind. But those are items that are available. And these are the Leave Behind cards that they have designed. So we would just have to get these printed so we could put those with kind of whatever is decided that's distributed. And this is what connects people to that, to the treatment when they are ready for it. So if it is, they don't want to be connected to treatment, but then they kind of sit on it for a couple of days, they can call the telemedicine provider. Yep, it is 11 a.m. to 11 p.m. That's confirmed right here on the screen. So when they're ready to be prescribed buprenorphine, but then with the ultimate, they're going to want that person to be seen in the community for long-term care. So that's the general overview I will give. I'll take it unless anyone has questions, or if there is a group that would like something more in depth, I'd be happy to facilitate that as well.
So how are agencies going to sign up?
So how do we get agencies signed up for it?
Our plan was going to be to sign up as the program agency. So it's just one form that needs to be filled out, but then the training that happens, so individually it's going to take work on the program agency to what individual agencies within the program agencies, who wants to do what? Do they want to just be the Leave Behind and have the materials? Do they want training on the referral platform? And if so, we'll connect them to do that training. And then also we can provide the Leave Behind items as well. Does that make sense? Does that work?
I just think we should have some stuff that's spring fling on this.
Definitely, yeah. We can have the slide deck for sprinkling and a lot of the information.
We could have that plane, we'll set up a table, have that plane there, and we may.
Get some agencies on the hook for it.
Yeah.
Because, oh, Lindsay froze. Oh, there she's back.
Okay.
One of the big things though that is being identified is there is just this huge gap from where EMS treats the patient who's initially having that overdose to actually getting into definitive care and being taken care of. So our attempt with this is to help, and Samaritan is pushing forward with it too, is to help close that gap. So less of them are falling through the cracks.
So this would be on 3
With an
counties.
expansion of the Leave Behind program for the Narcan opiate kits to begin with.
Right.
And this is like kind of.
And with us already being opiate prevention site,
Right.
It's not gonna take us really much lift to change our agreement to be able to start doing it. I have to report on if we do any leave behinds anyways.
All 3 counties, correct?
Yep.
So is there
I
a
would
point
know. Go ahead, sorry.
is there a point of contact we can push this stuff to?
It'll be me for right now.
Okay, so
No, I don't think it includes in Lewis County though. Should be Jefferson, St. Lawrence.
But we should be able to push into Lewis, wouldn't you think?
Yes, so the plan is, well, Lewis is probably more set up than maybe a St. Lawrence because our treatment providers are really concentrated in Jefferson. So I'm guessing those Lewis would come to Jefferson for that. I could be wrong unless they head the other way towards Utica. That network's not, that it doesn't exist. So the network we're trying to build is the 3 counties, concentrating first on Jefferson, because as I mentioned, Jonathan pointed out, Samaritan was a great partner in getting this going, and we've kind of just grown from there, and we are slowly kind of expanding because it does take it does take all types of providers.
And really, the reason why we were talking about this here is you're all the docs. You're the ones who are the medical directors for a lot of these agencies that may be partnering with it. And if this raised red flags with you as medical directors, then we would probably maybe pump the brakes a little bit and look at it from a different angle. But if we have the support of the docs, I think it'll help us move this program forward quicker and smoother.
All right, so it sounds like we'll get something together for Spring Fling, and then if anyone wants additional information, please reach out to Jonathan and he'll facilitate. I'm kind of just a spokesperson on behalf of FDRHPO, but really we can get the Matters program contact in as well to talk to anyone's team if that's what we want to do.
Any questions for Lindsay on this?
I'm thinking we can pitch it because we can give them C&D credit for it. For behavioral emergencies, additional, whatever, so I think that we can, is this training we can put in the LMS?
I don't know, but we can look into it.
Right now it is a live interactive training. So I have mentioned we have the LMS. It would be, it would just wouldn't have that Q&A component. So we could see if that we could develop a version that could live on LMS. I can take that away.
Perfect. Thanks, Lindsay.
Thank you. Have a good night, everyone.
All right, we'll keep rolling right along. Air medical reports, they were sent to me probably about 10 minutes before the meeting, so I will email that out to everybody after the meeting. Matt, do you have anything to add though from Mercy Bites?
I see Colleen's on.
Oh, Colleen is on.
I'm in the elevator.
Oh, you're not trapped, are you?
No.
It tends to happen in this building, so. State EMS meetings, we'll jump to that and then we can bounce back to Colleen. Go ahead, Mark.
All right, so we met a couple of weeks ago in the exciting place of Albany. The highlights, there's a whole bunch of regs coming out. There's a whole bunch of stuff in the budget that's proposed. And the highlights of the stuff in the budget that's proposed, this is not passed at all yet, is essentially a paramedic-driven urgent care through telehealth, opening up community paramedicine and changing the definition of EMS to be able to do everything but sell ice cream on the corner. There's protocol changes coming out July 1st. A lot of it was really just some wording issues. There is some antibiotic pilots that are being discussed and looked at and waiting the commissioner's approval. And kind of really the biggest thing that occurred is they have elected to sunset the EMTCC starting at midnight on July 1st of 2024. They are working on increasing 27, I apologize, too many dates. They are working on ensuring that there's plenty of the bridge classes available so people can take them. But the current bridge programs have almost nobody in them. there's going to be, and there's some performance and quality initiatives that are going to be worked out over the next couple of months that are going to kind of hold agencies' feet to the fire on some different things. So that's about the excitement of CMAC and SEMSCO.
Any questions for Mark? Now that Colleen's here, we can do air medical. She's not trapped in the elevator.
Okay, I was trapped. That's what caused my delay. Yeah. So when it comes to the three counties, I was able to, and you'll be able to share.
Yes,
the
I'll email
attachment.
that to
Okay,
everybody.
thank you. Yeah. So we have a new program which breaks down the time of day, where the calls went to, meaning hospitals, things like that. And these are specifically only for our scene calls. It does not have any hospital data. So for Jefferson County, for the year of 2023, we had 687 requests. And out of those 687, there was 155 transports. Out of Lewis County, there were 102 requests and 28 transports. And then for St. Lawrence, 189 requests and 57 transports. And then what I'll do is the next meeting, I'll give you Q1 data and information. So, and if there's any more information that you would like that the new format doesn't have, please reach out to me and I'll be happy to share.
Thanks. All right, moving into other old business. So I put this under protocols because I didn't know if there was really any other place to put it. So Fort Drum ambulance request for ketamine to be a standing order for adult patients.
So when we looked at the protocol, it is a, first dose is without order, but then the additional doses does require an order. So that first round is a standing order.
And that's 250 milligrams IV, IM, whatever you choose. So
Because.
that's 250 milligrams for the initial dose. It's wide open without any requirement for order.
So I guess the question is, and it's not really clear from the request, is that for additional doses to be a standing order, or which I can work on finding out that information.
What was the correspondence? Was there a request specifically or?
Yeah, that letter I showed.
Yeah.
Yeah, the request was for this reason, I'm making all protocols which have ketamine in them standing order for adults only. So it doesn't specify, but we are assuming it means subsequent orders.
What other protocol wouldn't ketamine land in other than behavioral would be the one for excited delirium, and it's 250 for the first dose, but the only other one I can think of would be like sedation post intubation that it would fall into, but even then it's a option and then an order.
So
And
it
they're,
sounds to
it
me
sounds like they
they're-
want it for pain,
It sounds to me like they're just doing it.
but
They're
it
not
sounds
asking
like,
for
but
permission.
they're saying, well, I guess I don't know. They don't specify. They say evidence supports that ketamine can be a superior medication in comparison to other narcotic medications. So I
Which I-
guess I don't know.
So there's,
Procedural sedation.
so for pain management, I mean, we're talking a drastically different dose. We're talking
Very
like
different
0.25
doses.
per kilo
Very different.
versus 250 milligrams. You're talking 25 milligrams instead of 250.
It's a med control order for procedural sedation.
Right.
So do we just want to table this and get a better understanding, Jonathan, get a better understanding of what they're actually asking
Well,
for?
it doesn't sound to me like they're asking, they're telling us. For this reason, I'm making all protocols which have ketamine in them a standing order.
Is there a name on that request?
It's Dr. Beedry.
And it came from Saxon, Chris Saxton.
Okay.
Well, we can find out and get back to you.
Is there clarity on what protocol? Because I mean, there's three profoundly different protocols that would fall under,
Yeah.
which would be subsequently three profoundly different doses. And I use ketamine on a regular basis in the helicopter EMS world, and I can tell you that there are some untoward effects, and there is a national shortage here. I don't know if the military has the same problem we do, but there is a national shortage of ketamine. So even we reserved and redacted our use of ketamine and post-intubation sedation and changed our formulary for RSI and don't use it as frontline pain management. We opted for multimodal, like acetaminophen at a gram, and then ketorolac and fentanyl and other modes versus utilizing ketamine as frontline for analgesia, because it really truly does have other properties. And if not administered appropriately, causes some significant side effects that are undesirable, you know, so. I mean, just from my perspective, and the REMAC obviously has the ultimate decision here, but from my perspective as a paramedic who uses it mainstream, I just don't ever want to see an actual clarity to what protocol and what use intended for this drug, because there are some significant, you know, impact to the frivolous use of this medication, I should say.
And the other thing is, we're part of the collaborative protocols through New York State. So everybody, with the exception of New York City, is on the same protocol. So we have to, if we want to make a change, we have to present it to the CMAC. And then those changes go in effect July 1st of every year. They used to piecemeal it, and they were finding it was too hard for people to keep track of what the protocols were. So they say as of July 1st, any ones that are approved are going to go into effect at that time type deal. So this is really got to go to the CMAC.
The other side of that is they could, quite honestly, develop their own standard of care, but they'd have to go through the same process that Air Methods and Mercy Flight Central went through, where we created our formulary, submitted to state council, go through the rigorous process of approval, and then each time we amend ours, it goes back through that process again once a year. So whether it's a subtle adjustment in medication or whether or not, you know, something falls under an order versus an open-ended, you know, standing order, you would have to go back through that process each time there was an amendment or change. So if they're looking to adhere to state collaborative, as Debbie suggested, or if they're looking to create their own standard, again, that would be much more than a MOU or a letterhead stating they wanted to change something.
So we'll table this until, and we'll get some clarification.
We can run it down
We can always
tomorrow.
bring it back.
Is there somebody that we should direct the question to, or?
So Chris Saxon is the one who sent
Right,
it.
but I mean, back to you guys.
Me.
Okay.
We'll get you one of his business cards.
Okay. I think I've got it.
Okay.
Okay, what's next? Quality Corner Committee, Melissa, Brooke, now there's two of you on, so I need to clarify, sorry.
That's okay. We are currently restructuring our format, so we have nothing to report at this time. Jess and I are getting through Fort Drum EMS Day and then planning on revisiting that restructuring.
Perfect, thanks. Number 7, Medical Director MOU, so those were sent out. We have not gotten a lot of them back from agency medical directors. In fact, I think only 3 medical directors have completed. Dr. Gray, maybe, I don't know. Dr. Gray has, I think Dr. Holliday has, but his agency hasn't signed it. And, as well as
Dr. Gerard.
and Dr. Gerard is signed.
Oh, there's one more. Dr. Pierpont has.
A name?
I can't read it.
Okay. So we'll move on to the magic number 8 that's not really on the agenda, which is the sepsis results. So let me, probably should pull them up on this computer and not mine.
So if you recall, I had presented to the REMAC a proposal for a suspected sepsis pilot. And we did start that, and I wanted to share the results that we had. We started it in November. And to date, we have done 5 screens. And One of them was a very sick 59-year-old male. Dr. Maynard was on. We called the sepsis and we got him right into a critical care bed at Samaritan, and we had great results. So all of these patients that we have done the lactic levels on, it's worked well. So if we have somebody with altered mental and we suspect it may be sepsis, when we're doing the finger stick for the blood glucometry, we're just doing this at the same time. So we're not having to re-stick patients. We're just doing both levels at the same time. And I think it's gone well. And I didn't know if we should discuss maybe sending this up to the state to see if they want to make it a statewide pilot, to see if we could get some additional data to be able to call the sepsis and recognize that, and hopefully have some better outcomes for septic patients.
Any thoughts? It's so quiet tonight. Oh, I think that's the reason himself. Nope, just kidding. Does anybody want to follow through with the recommendation to push it to the state and see if we can maybe get a statewide pilot started on this?
I'll make that motion.
Dr. Delaney? I have a second on it.
I'll second.
Dr. Maynard, thank you. All in favor, raise your hand to say aye. Any opposed, raise your hand, same signal. Okay. All right, program agency report. Let's mirror that. So we'll start off going with medical director changes. So these need to be approved. So Rutland Fire Department is going to Dr. Gray, and North Lawrence Fire Department to Dr. Coates. Does anybody have any questions about these changes? If not, I'd entertain a motion to approve the medical director changes. Dr. Holland seconded Dr. Delaney. All in favor, signify by raising your hand. Gotta remember which computer I need to click. It doesn't work if I click mine. So PAD updates, North Lawrence Fire Department to reflect the medical director change. New PAD organizations, FDR HBO finally has one. That was a fun ordeal. Watertown YMCA, the Fairgrounds YMCA, Blevins Auto Group in Governor, New Life Church of the Nazarene in Watertown, and the Turin Ridge Riders. BLS iGel, there's no updates to this since the last meeting. Although I know I probably missed something. Yep, you.
I was gonna say, come on now.
Yep, second meeting in a row, you gotta tell me.
I got it. I wrote it down.
Thank you.
I'll fix it between meetings. Regional BLS adjuncts, so we have 2 applications for BLS Narcan, Rutland Fire Department and North Lawrence Fire Department. We can vote on those and then we'll move down to, or do we want to just do it all as one bulk motion? Okay. For BLS albuterol, Rutland Fire Department, none for syringe epi or blood glucometry, and an application for BLS CPAP from Rutland Fire Department. I'd entertain a motion to accept those adjunct applications. All the appropriate paperwork's been filed with our office. Dr. Coates makes the motion. Do we have a second? Dr. Howland, all in favor? Perfect. EPCR, so we have 3 agencies in progress. North Lawrence Fire Department's going to the state's free image trend. Chameau Fire Department is going to the state's free image trend, and Rutland Fire Department is, I think, already live on the state's image trend. That's changed since I did this slide. So that leaves us only with 2 agencies left that are not electronic, Great Bend Fire Department and Potsdam Campus Rescue. So we've made a lot of headway with EPCR in the region. EPCR data integrity. So the NEMSIS 3.5 is now live. EPCR vendors have until July 1st to move to 3.5. There are significantly less data points that should make charting a little easier. We'll talk more about stuff to do with charting in a minute though. ESO issues have been semi-resolved. They've been resolved because the state has turned off the schematron for anybody who's on the ESO platform. So it didn't really fix it. They just shut the rules off for that software vendor. But it also means we're now getting data to flow through from the agencies to the region, to the hospitals, and to the state. The quality of that data is bad, for lack of any other way to put it. But we're at least getting it. So I'm gonna let Amanda talk now about the CQI initiative, because this is her, and Jess, you interject, and I'm just gonna sit here and not talk.
So I want to say like September, we came up with the idea of doing a CQI initiative. Initially, we were going to do every agency in the 8 counties every month, which we very quickly learned was very impossible because there are a lot of call volume agencies in both regions. So we kind of had to amend it a little bit. In January, we started this process. So any agency that runs over 100 calls a month or 1,200 calls a year will be selected 4 times a year for the initiative with a max of 5 charts each time. If the agency runs less than 100 calls, they will be selected once a year with a max of 5 charts. The charts need to have patient contact. They can't be cancellations or standbys. And I'm reading the refusal charts that are randomly selected to see if they are good data, because some of them are just like, patient didn't want anything. That doesn't really tell me much about your charting. So the categories we're reviewing is the identifying stuff, run numbers, date, and the type of call. That's mostly for the agency. We're looking to see if the chief complaint is documented. Is the history of present illness documented? Is there a primary impression documented? If it's not a refusal, did they get 2 sets of vitals? If they did not, did they chart why they did not get 2 sets of vitals? Do they have past medical history, allergies, and medications in the chart? Is the assessment complete utilizing the documented primary impression? Did the treatment rate meet protocol standards? Were there changes in patient condition? This one's more like negative changes in patient condition. And then we have a little note section where I can write notes to put in the agency summary. The agencies that are selected will get a summary of this with what we have found. February's have not gone out yet. I'm waiting for Jonathan to review them. We've also started pulling the number of charts uploaded for every agency on 8 counties, and they're going out in an email at the beginning of the month so that we can ensure the number of charts that the agency populated matches what's in the state image trend database. And agencies have been pretty receptive to fixing the discrepancy in numbers with that too.
Any questions about that?
That data goes to the individual chiefs of the agencies, or?
So it's going to whoever we have as the primary contact for the agency. There was some talk about maybe sending it to the agency's medical director as well. We did not do that for January. We just need to decide if we're gonna do that for February.
I know the request from the other region, from Mountain Lakes, is to have it go to their agency medical directors. That's just how they're structured over there, though. They have it, so if you're on the REMAC, or to be an agency medical director, you have to also serve on the REMAC, which causes them to not get a quorum very often because. Yes, but they have requested that we also share it with the agency medical directors. So that's something that we can do on this side too, if that's information and data you would like.
Is there a reason we can't do an Excel by month, just sharing the data here? So we can say you looked at this many charts, you had 100% with chief complaint, you had 90% with present illness, you had 80%. So we can see.
Yeah.
If there's a certain area that we're really falling short in,
I say it's easy because I'm not the one who has to do it.
I think documentation as a whole is a problem, especially narrative writing.
Yeah, narratives are rough. I've read some real gems.
but if we can show the statistics, then it's gonna be much easier to, and we already talked that maybe for next year's spring fling, we would do you guys would actually pull actual charts, good, bad, the ugly, and we would show them and talk about them and, you know,
I guess you could do it as like an M&M, like a morbidity and mortality talk, and then lean back on the documentation and show where, you know, it really doesn't support, you know, a good medical legal background. It just became a litigious thing, goes to court and patient died because of X, you know, here's all the reasons why you'd be in a lot of trouble, you know.
And if I find a chart that I have red flags about, I usually go to Jess first, and then I make a list and I do review those charts with Jonathan. Or if there's a really, really good chart, I also bring that to his attention.
Yeah, if there's a complication for something, we really sit there and break it down by careful review and then taking it all the way back to protocols very specifically.
But we've. found
Amanda, I have a question on when you guys are saying the chief complaint documented and the present illness, et cetera, is that in the drop-down boxes or in the narrative section as well?
Specifically, I've been looking at the drop-down boxes. There are some agencies that don't put very much in their narrative, so there is that.
Perfect. Can we link up sometime? Because I have some stuff that would make Quality Corner a lot easier if we could start including in some of the CQI initiative as well. And I do have a recommendation of looking for any conflicts between drop-down boxes and narratives. When I do chart reviews, that's probably one of the most common errors I find is they'll say something in a drop-down box and then say a complete opposite. Whether it's agency preset settings or they just they miss something along the way.
Assessment tab.
Yeah, the assessment tab, you know, where they'll have, you know, everything normal. And then in the narrative, you know, your patient is not normal in any way, shape, or form. And those are some kind of things that get picked apart in a legal setting as well.
The assessments are notably a problem across the board for almost, not all agencies, but there's a significant amount of charts that have a very poor assessment or almost no assessment at all.
And then you run across the cardiac arrest chart, that
That's
is
one
4
sentence.
sentences.
One sentence.
One sentence. They were dead. Great. Thanks for painting that picture for us.
Debbie, when you're talking about spring fling next year and you're saying the good, the bad, the ugly, what's your thoughts on running a mock trial? And we can talk about it later of, you know, we pick a chart and put somebody on a stand and make them defend it.
3 or 4 years ago.
Yeah.
Yep,
Oh,
It was fun.
but we can do it again.
So we do have CME evaluator agency application, so they are provisionally approved. We need the final approval. So Lisbon Volunteer Fire Department. Ann always used to do her CME stuff out of the office as program agency director, but now since she's not here anymore, she actually needs to make her agency a site so she can do their CMEs.
I don't think so.
So can we have a motion to approve Dr. Delaney? Can I have a second? Dr. Maynard, all in favor? Perfect. So we just ended the CME semester. So our non-compliant, so providers non-compliant, so that means they did not complete their CMEs for this last semester or year if it's a BLS provider. Which means that they cannot perform the BLS adjuncts. And if they're an ALS provider, it means they are not in good standing and it's been turfed over to their agency medical director because that is how we have to do it now, whether we agree with it or not. So we have 47 providers that did not complete their skills or remain non-compliant. 4 of them are ALS providers, 43 are BLS providers. We had 4 providers who came back online from being non-compliant. 10 providers, 5 and 5 each, ALS and BLS, who are out on either a medical or leave of absence. Which compared to other years, the ALS numbers are so much better than what they used to be.
Is this score back online? Are the combination of ALS and BLS?
I think they were ALS providers that came
Yes,
back.
and that number is higher. I had people put skills in today.
Okay.
I sent out at least 2 letters today of good standing, so I think it's probably 6 or 7. I did not update that number when I updated the top numbers.
That's okay. But agencies are getting a lot better because usually the process of doing everybody's credentials at the end of a semester and making sure their skills were in was usually about a 3-month process of tracking down where people actually were running again. Because, you know, everybody gets mad at an agency, decides to leave and go to another agency, then gets mad and goes to another agency. They aren't good at telling us at the program agency where they are. And they've gotten a lot better because we really didn't have to track anybody down this semester. It was nice. Well, I say it was nice. I didn't really have to do much of it. That was good.
It was not nice. Thursday and Friday were not my favorite days.
So upcoming trainings, we have Fort Drum EMS Day, which is gonna be this coming Saturday. We have 19 providers registered. A handful from the North Country region, but actually quite a few from the Mid-State region. Old Forge is sending 3 or 4 people. We have a couple coming from Mountain Lakes region. We have somebody coming from Long Island. I think they're a college student, and that just happened to be what their address was. But we're really excited for it. We've got a lot of really good scenarios lined up. Melissa and Jess have been working pretty hard on that as I just jump into the call and then have to get off because somebody else is calling me. So things are moving together really well with that. Spring Fling, we have roughly 40, actually that number's gone up since I put this in. And we have 8 vendors registered, but that does not include Mercy Flight. So 9, and then we had 3 or 4 reach out last week requesting more information, needing like a W-9 so they could start the process and that kind of stuff. So we're moving along pretty good. Debbie, do you have anything to add?
No, just, you know, we tried to get the stuff out earlier because it is early this year. And Clarkson has taken the lead on the Friday ALS and BLS core, and we're gonna get the brochure updated to show the classes that they're gonna do for that, and hopefully that'll entice some more folks to get signed up. We did send letters to all the area hospitals requesting a donation to help keep the cost of the conference down. And we've heard from a couple hospitals already that are going to send us in some money to help cover the costs, so.
So Pulsera update. So hospitals are going live on Pulsera March 5th. So you've heard me talk about Pulsera at nauseum. We are actively working with our EMS agencies. We've started and we've gotten a bulk of the bigger agencies. Now it is more diving into the small agencies and getting them signed up and getting their people signed up as well. They are going to record a training. It's going to go on their New York State resources page, but also is going to go on our learning management system as well as a means for people to get the training. The only hospital that so far has not signed up, but they have expressed interest, is not Samaritan. I saw the look. It's River. They do want to sign up for it. It's just been tough coordinating calendars to be able to get Christy and I on the phone together to move through. You still have it in there?
Christy Farrell?
Yeah.
Yep, I'll get ahold of her.
Okay.
And
Thank you.
how does Fort Drum get a hold of her?
So Fort Drum ambulance is already signed up for it.
How do I get a hold of them?
I'll get you there.
Okay.
I'll get you there.
Is this replacing the EMR resource, right?
Right.
Yeah. I appreciate it.
I have a clarification. So when we have Pulsera, we'll have the capability of sending over a 12 lead. So if we want to do this at the BLS level and it's compliant with the hospital, all of the agencies that have that BLS capability will have to submit an application to our office, correct, for approval?
Yes. Right.
Say that again, so if you're already doing 12 leads?
For BLS, if a BLS agency wants to do BLS 12 week, they have to apply through our office to
Right,
do it.
but if we'd already done it,
We're good.
Okay.
Yeah.
And I say, we've already been, we transitioned to it when the mid-state region went to Pulsar because of when.
Yep.
Yeah.
So we have a new website, and in turn, REMAC and Remsco has a new website, and I'm gonna let Amanda talk about it.
So I
Because
was.
she did it all.
Yeah, I was tasked with creating our new website. It was.
It's a lot of fun.
I've never done it before, so it was rough. So this is our homepage now. Our mailers are still going out through MailChimp at this time. I think eventually we will transition that. Right now I am making them separate and what's posted on the website. Our news page is here. It actually is a blog now. So all the fun news and stuff we have is gonna be posted there, and they'll go out in the weekly mailer as well. All of the same links as before are on our page. REMAC and Remsco has their own page. I did add the bylaws.
Thank you so
While you
much.
guys were at dinner. So the REMAC policy handbook, the meeting schedule, there is a separate page for SISM, and then the Remsco bylaws are on there. It's basically all the same stuff that was on the previous website, just it looks a little bit different. Show you SISM's page too. So SISM's page has how to activate it. There's click here for more information, and there's a membership application as well.
Can you go back to the main page above? This page. So I just want to kind of throw this as a little, if we don't immediately call you back, that's the map of all the agencies that are under the program agency now. So please know that if I don't call you back immediately, or somebody from our office doesn't call you back immediately, it's not because we don't want to talk to you. It's chances are we're talking to one of those other 200 dots. So I just ask you to bear with us, and we will get back to you as soon as we can. It's not because we don't want to talk to you. It's just probably because we're tied up with something else.
Did I see you had the pulse in there? Because that's under new business.
Yep.
That we can.
I should add this to
Go upside.
the REMAC and Remsco
Yep.
page.
I'll let Debbie talk about this.
So, our second newsletter, was mailed out. It should have gone out 2 months ago and it did not. So that's gonna be discussed at the, Remsco meeting. But we are MailChimping it to over 350 elected officials, that represent the 3 counties. So we talked about this time, the cost of ambulances, fuel, things like that. Move down. Keep going, that's all one article. We featured Raleigh Churchill and did a role reversal from paramedic to patient. For those of you that know Raleigh, he was a paramedic. He was the initial director at Tears and had a sudden cardiac arrest a few months ago. And his family started CPR, and law enforcement showed up and took over, and the ambulance wasn't far behind, and he had a full recovery because of that. So I'm working on getting some funding. I have a follow-up call with Kinney Drugs next week. And I'm gonna try to push a program to encourage organizations, businesses in the 3-county area to get AEDs and to get trained, and that we would help cover the cost of that. So that's the grant that I'm trying to get. And I'm going to call it Raleigh's Charge. So I'm hoping that I can get the funding to make that come alive. So we had stuff on the EMS salary survey, which came out from the state. We put that in there. Talked about legislation. We wanted to thank our elected officials for having so much in there for us this time. And then we ended with, what does a star of life mean? So Again, this over 375 of these went out. And we will be meeting and working on we will be working on the next one as well. So,
I did click one of the links to the survey. The PDF that showed up, it was kind of wonky in its format. That was the only like kind of catch I saw to it. And I don't think that's under our control. It's just, I think it's just the link that goes to it. I put the
okay.
So miscellaneous stuff. We participated in the state quality metrics, state legislative committee, state data and informatics. Zach and I are on the EMS, NEMS 3.5 update education team. Attended state meetings December, February. The next meetings are May 7th and 8th. The EMS memorial is May 22nd, 24, and the state hopes to have the new memorial completed at that time. Miscellaneous stuff, the CNY Health Emergency Preparedness, the Northern New York Child Fatality Review Teams, Meriden Stroke Center stroke meetings, upstate stroke quality meetings, Jefferson County MIH, Jefferson County Hazard Mitigation Steering Group. And if you have any paperwork, please submit it to our office at that address there. Does anybody have any questions for the program agency?
Did the mutual aid thing, but on that here,
Cool.
Can I add one more thing?
Yes.
For the docs in the room and on the line. So I am working on both of our LMS with education. Matt Yelton has been gracious and has our first two that have solicited with the exception of Dr. Bombard. But if anybody has a topic or has the urge to help collaborate with me to help facilitate more education on our LMS on a variety of topics, we are not shy to what they are. If they're unique to you or you have a core content idea, please let me know and reach out, or I can reach out to you. We have sent out a survey. It has not gone well. There was a lot of interest when we sent out our primary survey of topics, what people wanted. Some people were interested. We sent out a follow-up survey. It may have gotten lost in the mix of a bunch of different communication that went out. We've only had 2 responses for people that were interested without in our 8-county area. And I followed up with them and I've gotten no response back when so if push comes to shove, people don't actually really want to do it. But if you do have a topic that's out there or you're interested, please let me know. And I am looking at you. I will probably email you individually as well, but I just wanted to put that out there. Or if you know of any educators or anybody that's interested in becoming an educator, just has a topic, I will absolutely work with whatever level is out there that would like to move forward in that direction. That's all I had. Thank you.
Okay, new business. We already talked about the Matters program. We've talked about fall. April REMAC meeting date. Voice crack there. It says April 1st, but Dr. Delaney isn't available on that day. So we're requesting to change the REMAC meeting to the 15th. Same time, same locations. Be a week after the eclipse and the week after spring fling. Can I get a motion to make that change? Dr. Howland, Dr. Delaney, seconds, all in favor? And then other new business, because I didn't put it on, Melissa Lockwood from the state is here. So Melissa, do you have anything you want to bring up per se? Melissa?
Unmute Melissa.
Try.
Can you hear us? We can't hear you. All right, well, while she gets that together, Dr. Bryden, do you have anything? We do have the folks from Samaritan's Trauma Program here. You can introduce yourselves if you want. We all know you, Dr. Bryden. You've been here before.
I'm Dr. Bryden, the trauma medical director for Samaritan's hopefully soon to be trauma program.
I'm Michael Briggs. I am the Trauma Process Improvement Coordinator.
And I'm Chelsea Schmidt. I am the trauma program manager.
excited to work with you guys and see the program move forward.
We are too.
Melissa, do you have anything? Not you, Melissa, other Melissa. I saw Melissa perk herself up. Oh, God, no. All right, hearing nothing else, does anybody have any?
I do. I would like to recommend that we send certified letters to the CCs in our region. We'll have Dr. Delaney sign it, notifying them officially of the end of the CC and giving them options on what to do to maintain it. So before we do that, I think we should see what agency it says they're associated with, reach out to that agency, confirm we got a good email, and then send it to them and the medical director of that agency as well. But I think their letter should go certified so that we don't hear from 2 years from now, I didn't know that I was gonna lose my card and our agency's gonna fold because I can't operate as a CC. And I'd be glad to help write that letter to have that happen.
That was good.
Just probably see if anybody objects to that. I just think we should do something to.
Does anybody have any objections to that?
I think we identified 11 for our region, right?
I believe.
Yeah, because
Yeah.
the higher region was Mountain Lakes. They had like 50 or 60, so.
Yeah.
And the majority of them were age demographic with no interest in getting certified there.
Yeah.
Right, yeah, but that way it's. There's
They
no-
can't say that they didn't know. Any other new business? Okay, hearing none, I'd entertain a motion to adjourn. Dr. Coates and Mark. All in favor? All right, thanks, everybody. Have a great night.
So we do have some providers who.